Good afternoon. My name's Chelsea Menchen. I'm the National Projects Director at Palliative Care Australia, and I welcome you all to the National Palliative Care Standards Community of Practice webinar series. In the spirit of reconciliation and allyship, I'd like to acknowledge that we are all coming together today from the many and varied lands of Aboriginal and Torres Strait Islander peoples across Australia. Today, I'm on the lands of the Ngunnawal and Ngambri peoples, and this land was never ceded, and I pay my respects to elders past and present. For both sets of the National Palliative Care Standards, so for specialist providers and also the National Palliative Care Standards for all health professionals and aged care services, there's 9 standards across both sets of standards. And at a high level, they're consistent across both sets of standards. So the expertise you'll hear from today will bring the perspective across all the care settings across both sets of those standards. But firstly, Kate Ritchie, the PCA Senior Project Officer, will provide a bit of an overview of the standard that we're looking at today and its intent across those settings. Then, with our panellists, we'll discuss how the elements of the standard can be embedded into day-to-day practice. So the simple ways to integrate this into your practice. And then we'll follow through with a Q&A from the audience. But finally, Kate will then take us back through the next steps, including how to use PACSA, which is the self-assessment tool that you can use for checking yourselves against the standards, and how to join the National Palliative Care Standards Community of Practice. And that's where you really get to get into the resources that can help you. So without further ado, let's meet Kate Ritchie.
Thanks, Chelsea. Standard 4 supports care that enables people to live as well as possible to the end of life through timely, coordinated, and person-centered care. Standard 4 focuses on delivering care informed by comprehensive assessment and aligned with a person's documented goals, values, and preferences. It emphasizes anticipating needs and responding in a timely and coordinated way as circumstances change. The standard also recognizes the importance of innovation and continuous improvement in the delivery of care. Services are encouraged to ensure clinical practice is informed by emerging evidence and advances in technology. When services are unable to meet a person's preferences, the standard encourages clear explanation of reasons to the person, their family, and carers, along with a discussion of appropriate alternatives. Any concern or worry that a person has unmet care needs should prompt a review of their goals of care and treatment plan by the lead clinician, resulting in timely recommendations for follow-up and ongoing communication. I'd also like to acknowledge and take a moment to acknowledge that it is National Volunteer Week and recognise the invaluable contribution of volunteers make across the palliative care sector. And then I'm just going to briefly talk about PACSA. So as you're listening to today's discussion, I encourage you to reflect on your own practice, your team, and your organisation. The Palliative Care Self-Assessment, or PACSA, is designed to support reflection against the National Palliative Care Standards. The National Palliative Care Standards themselves are aspirational. There are no minimum standards. I encourage services to use them by recognising what is already working well, celebrating wins, and using them to guide quality improvement initiatives. PACSA is service-driven, and it includes an action plan to help services identify and prioritise their own next steps for improvement. It can be used within teams to support quality improvement and planning. For specialist palliative care providers, there is a dedicated PACSA assessment pack for Standard 4. This works through each of the elements of the standard, and these are the same elements that we'll be discussing throughout today's webinar. There is also a checklist for all health professionals and aged care services, and this can be used individually or as a team and revisited over time to support ongoing reflection and quality improvement. So as we move through today's panel discussion, I encourage you to share in the chat what is one thing in your service that relates to Standard 4 that is working well, and one thing that you would like to focus on.
Thank you, Kate. Okay, let's introduce the panelists for today's discussion. Today we have Bronwyn Arthur joining us. She's joined PACOP as an improvement facilitator in March 2022. She holds a master's degree in palliative care in aged care through Flinders University in South Australia. Bronwyn is a registered nurse and has worked in various roles in her career, namely as a clinical educator and as a clinical nurse consultant. Her passion is the care of people living with dementia who are often undiagnosed with palliative care and end-of-life needs. Her work history includes specialist palliative care, specialist aged care in the acute setting, and specialist residential aged care. We've just got a bit of feedback on your end there, Bron.
Okay.
Also joining us today is Sarah Begley. Sarah is a palliative care clinical nurse consultant with over 16 years experience, mainly in community palliative care. She currently leads a clinical team at Danila Dilba, supporting Aboriginal and Torres Strait Islander elders in the Darwin community, and is the Vice President of Palliative Care Nurses Australia. Her work has included roles in Far North Queensland, rural and remote New South Wales, metropolitan services, and also in India. She has also worked as a clinical nurse educator, developing EPC Foundations, a 10-day simulation-based program for community palliative care workers. Welcome.
Hi.
Welcome to the show. So we might jump into some introductory questions. Sarah,
sorry. I was jumping in.
Off you go. Sorry.
Oh, okay. So Sarah, were you introduced to the National Palliative Care Standards at the beginning of your practice, or were they introduced later? And how have they influenced your practice to today?
So I, if I'm very honest, way back when I was a new community palliative care nurse, I definitely did not know about the palliative care standards. But I suspect that they were running in the background, and my service that I was working for were absolutely aware of them, and I was kind of the instrument to enact them, but I didn't know, I wasn't aware of it. But the first time I became aware of them was when I was volunteering for an organisation called Apply, where we went as doctors and nurses to support new palliative care services in India. And part of those visits was to bring the palliative care standards and kind of talk about using them to develop and support growth of services. So that's where I first became aware of them. And currently, as in the service that I'm in at Danila Dilba, which is new, the palliative care standards have absolutely helped me set the goalposts for where we need to be. So that's how I'm using them currently.
That's great. And Bron, I'm going to go to you. So for somebody who may have not heard of the standards before, what would you tell somebody who is learning about them for the first time?
So obviously from my program, Palliative Aged Care Outcomes program, I work with residential aged care primarily, and then the supported home groups. One of the things that I do talk to them about, because most commonly they do not know about the National Palliative Care Standards, is how these have actually underpinned the strengthened standards. And when you look at the strengthened standards, there's many applications of the National Palliative Care Standards within them. Obviously, the standard 5 in the strengthened standards in residential aged care and community is about clinical care, and standard 5.7 is specifically about palliative care. So when you have a look at standard 5.7 and you have a look at standard 4 in the National Palliative Care Standards, you can see how National Palliative Care Standards have actually underpinned and supported the development of standard 5.7. So when we talk about standard 5.7, in our program, we talk about the origins of where the palliative care support and information came from and reference the National Palliative Care Standards, particularly ones that are aimed at all health and aged care, that part of the program, that part of the standards, palliative care standards.
Fabulous. Sarah, I'll just go to you. For Standard 4, it highlights the importance of care being delivered promptly and in accordance with changing needs and preferences. Why is a comprehensive assessment and care plan foundational to quality palliative care?
I think a good assessment is really what is one of the core skills of a palliative care clinician. And it really is I think it's our tool to be able to, a really good assessment centers the interaction on the patient. And it's our best, I feel like a kind of a really comprehensive assessment kind of woven into a conversation is one of our best tools, I think, to be able to demonstrate to the client that they've been heard and that what matters to them matters to us. I think a good assessment also gives us the best information to make sure that we're responding, we're picking up what's going on and responding in a way that's going to be useful for the client. I think too, so I used to run, one of my previous jobs was putting together an intensive boot camp for community palliative care nurses. And really that kind of core piece, which is a comprehensive assessment woven into a conversation, really was the kind of the cornerstone of this course. That was what we needed those nurses to be able to do. So it's a core skill. And then I'd say a care plan is like the manual for the client, and a good community palliative care service will have that very easily accessible, and it will, a good care plan will tell you all the essential information about a client that you need, and it can be about their symptom management, but it also can be about things that anticipatory care, things that are going to happen in the future or might happen in the future. And I think a good care plan too, I've been at services where we've had like mandatory items in there, which are like preference of end of life, support medications, skin integrity, mouth care. And I think those items orientate the team to what really matters and kind of communicates what needs to be done. So, and in fact, in my old service, I used to write in the notes, I'd do the care plan first, and then I would write in my notes, see care plan. Like, that's how important I used to think the care plan was. I think too, the last thing to say is that I think for a community palliative care service, the care plan can also hold items that are important for your own safety as well. It might have risks or things that we need to know to be safe in the community and deliver palliative care. So yeah, both things are crucial.
Yeah, fantastic. Bron, the generalist standards emphasise that a healthcare provider with overall responsibility for coordinating care must be clearly identified. How can organisations ensure that clear clinical accountability in environments where there might be multiple providers?
Okay, so you're right about multiple providers. So let's look at residential aged care and also the community, so supported home. You are likely to have a GP involved, sometimes specialists, including geriatricians, in-reach teams. This could be specialist pal care teams, can also be geriatric teams, and it can also be NDIS. So the key person in these contexts is supported home would be a case manager, often an RN. And in the organizations, care managers, sometimes known by different names, but they're usually clinical care managers, manage and support the overall care of the residents, so case manage the residents. I think the standards require evidence of them being met. So there's the standards being met. How does that get done? I think there are numerous ways where mandatory information is collected using quality indicators. There's 14 of them that the aged care facilities have to use every month.
Yeah.
And that looks at things like weight loss, falls, skin integrity, and so on. So they're collecting that information. There's also the serious incident response scheme, which is picking up on, that is coming from me, isn't it?
It is, yes. I'm sorry. I'm not sure what it is.
So, okay. Maybe I need to talk on my phone. I don't know. That's a thought. So there's also monitoring serious incidents. So, and I think that you've got a group of people, the execs, you've got care managers, facility managers who'll be monitoring all of that.
Yeah. Okay. Well, we'll go to Sarah again. Sarah, Standard 4 highlights discussing and documenting preferred place of care and death, which you spoke about before. These conversations can be quite challenging. And when is the right time to begin them, and how do clinicians build their confidence to be able to initiate them?
Yeah, the first thing I want to say about that is that I remember so well feeling so nervous about those conversations when I started in community palliative care. And I also remember those conversations being clunky at the start. Yeah. And I guess my kind of tips with those conversations is just to acknowledge to yourself that the only way to get better at them is to have them, to practice. And my other tip is to try and be as authentic and genuine as you can, because I think their clients and patients have radars and they can tell when you're speaking and they can tell when you're pulling their leg or you're just not giving them information that's yourself. So for me, over the years, I've learned that really the best way to approach these conversations is honestly and genuinely. And I'm going to go out there and say that I actually love having those conversations with clients. And I think as a community palliative care nurse, I guess it's worth checking in with yourself, because we often feel like we're going to upset the client. But I think most clients actually expect us to bring this up, and so it's just worth reflecting where the angst is. Is it with you, or are you thinking that actually are you putting something on a client where you haven't actually tested that?
Yeah, I think that's a really good point, Sarah, because if you aren't going to raise and talk to those questions and create that space, who is?
No, totally. And I think as a community palliative care nurse, it's our job, right? But there's a caveat to that. That is, there's also skill to it, right? And the skill is to be able to, you don't just launch in with an agenda. You got to read a room. You've got to go in and get the vibe of the space you're in. You've also, what I do is I fire warning shots. Was what I say. I kind of which is kind of, I'd say something like, and another thing that it's important that we talk about is X and Y. One of my jobs as a palliative care nurse is to talk about death and dying, but we don't have to talk about that now. You just, and then you drop a little shot, and then you just read the room.
See how it lands.
And sometimes that's all that's needed, and it opens up a whole conversation, and you're that person for them. But sometimes you plant a seed, and the next person you get to really get the fruit of that seed that you've planted. And I guess the other thing to say is that I think being straight up is really important with clients. Being honest. And I think they can read when that's not happening. And I think these conversations, if possible, need to start on admission. That we're palliative care nurses, and when appropriate, we are the right people to talk about this and make sure the clients feel safe and know that we are the safe person to talk about the topics that they can't talk about with others.
Yeah, that's right. You're the people they can raise those concerns with. What about outside specialist palliative care, Bron? The standards emphasise that care must be responsive and delivered properly in line with changing needs. But how critical is it that every member of the care team, including non-clinical staff, particularly in care settings, is supported and empowered to recognise and escalate subtle changes in a person's routine? I think we've got a bit of feedback from you, Nick. Are you moving stuff on your desk?
Me?
Yeah.
Oh, yes, I possibly am. Sorry.
Sorry. So that one's for you, Bron. Can we just, yeah.
Yes. So I think there's a couple of things there. I think I'm just going to go back to a point Sarah made about talking, and in residential care, you often have staff who feel inexperienced in having the conversations. So a lot of the time when we do talk to facilities, when we're doing our training, conversation about, or the thing about difficult conversations comes up. Our recommendation is, particularly using PACOP, the PACOP tools are a framework. The first part of the program actually screens on a routine basis all residents in care. And this would probably be the same context in home support. So we're piloting this program in home support in the second half of this year. Having the opportunity to screen regularly means that you've got a point of comparison from 3 months ago, because the cycle is a 3-monthly cycle. There's also a deteriorating resident tool within that screening process. So if you can take those tools to families and have a conversation and show them the tools and be transparent, we encourage that the staff do this, because in its own right, organically, it starts a conversation. And if you have a point of comparison, so let's say I did an assessment in December, I did another one in the end of March, and I've done another one coming up in June. I have 3 points where I've done a review of someone. People who have frailty and dementia often deteriorate really gradually, and you can't always recognize or remember what they were like a few months ago. So that's a good starting point, being able to show changes. And then, like Sarah says, it's a conversation about, these are the things that are changing. You know, at some point in time, we will need to talk about what the goals of care are towards end of life. You know, should we be reviewing advanced care planning, because that comes up as a prompt in this part of the program. And I think that the responsiveness, and I'll use our framework, the responsiveness has the ability to be very quick using deteriorating resident tools. And at the same time, you've got this overarching 3-monthly cycle that's monitoring people. If you do identify that someone's got palliative and or end-of-life care needs, they transition into a part of the program that is a daily review. And then that facilitates daily monitoring and escalation. And there's an escalation matrix that we teach people, and we explain, you know, the scoring and how it standardizes language. And so when you're doing handovers, if you're beginning to use the handover, palliative care handover in your handover in general, everybody's across what is happening to the person, the seriousness of what's happening to them, and whether we've done an escalation and how quickly we need to do an intervention. So I think the standard 5.7 it asks for that. When you look at standard 5.7 in the aged care standards, strengthened standards, it goes through 5.7.1, 2, 3, and 4, and it breaks down, you know, what are you doing about collaborating? What are you doing about communicating goals of care? How responsive are you? What are you doing around bereavement? It's got a number of points in it that then are guiding staff, the aged care organisations, to develop something. So the other thing that aged care organisations have to do, obviously, is policy and procedure. And they all have palliative care policies. So, and when those policies are not enacted, it becomes a risk of not met when they have commission visits, which is part of their reaccreditation. So there's lots of governance around all of this. It's about putting it all into practice, and how do you make that practical for staff? And our finding is, with this particular program, with PACOP, it makes it very practical and pragmatic for them.
Yeah.
Including non-clinical staff, sorry.
Yeah. No, that's all right. I've also, to the tools, that touch point and being able to compare over time is also really supportive when you're having those discussions with visiting GPs as well.
Yes.
Because you can explain why you think certain things need to happen with your own experience as a clinical, you know, nurse within the aged care settings.
Yes. Because it's the subtle changes that are often missed.
It is.
So, I come back to my area of passion and interest, and that's your people living with dementias, and there's so many different types. We see the chronic illness trajectory. It's often quite dramatic when people become unwell. We think they could die. They sometimes bounce back. We know that there's a continuous downward trajectory, but the subtlety of a frailty trajectory, which in its own right is a diagnosis, and then the dementia trajectories, they are all relatively gradual. I mean, Alzheimer's disease has about a 20-year disease process once it's diagnosed.
Yeah.
It has a prodromal period before that. So it's a very long illness. And I think picking up on the subtleties can be really difficult. So, routine screening can help with that.
Yeah, absolutely.
So, Sarah, we're going to go. I know that we've had a discussion about this question, but I'd still like you to answer it. So the next element of our specialist standards highlights the importance of clinical practice being informed by new and emerging evidence. What recent innovations or evidence-informed approaches have been incorporated into your organisation, and what impact have they had on care delivery and outcomes?
Thanks, Kate. Yes. All right. This was the question that gave me some angst, because I thought to myself, oh my goodness, what? I don't have anything to say. But actually, when I thought about it, interestingly, it relates very much to what Bron was just saying now. So in the service that I'm currently working for, so community aged care for Aboriginal and Torres Strait Islander elders. It's 2 years old, the project, and I came on 1.5 years ago. And when we started, it was all fresh. And so we had no I set up my team, and we had no processes for picking things up and escalating. And so I went on to Palliative and got off the SPICT tools, which I thought were really good. And the SPICT tools then that I use, there's 2 tools. There's one that's kind of useful for the clinicians, and then there's another one that's in a very simple language for the support workers at my work. So I then kind of provided some education and support for my support workers to know what they needed to escalate to me. And now we have this process which works really beautifully, where we have an Excel spreadsheet, and they pop it on when they see any of these bits and pieces on the SPIC tool. They put it on the escalation sheet, and when I come in, I go out and visit the client or make sure that deterioration is followed up. So that's and I guess that has absolutely improved outcomes for clients. We've picked things up earlier, and I think also it's helped a bit of moral distress for the support workers who see these changes in front of them, and are worried about the clients because they know them so well. So now they know that there's a process where they can get extra help, and it works, and they feel supported. So that's my quality answer.
And that's a good one. That's a really good one. It's a perfect example of empowering people who can be your eyes and ears and enable you to take that step with a client when otherwise you might not have seen it until you were there next.
And community particularly I was just saying to Bronwyn before, it's a bit like the Wild West, right? Like everyone's just out there, and it's not like an aged care facility where you see the client coming past. You just, as an RN, you might not see those clients if they don't tell you what's going on. So those eyes and ears and the relationships with the staff and the team are really important.
Yeah.
And action once that observation has been observed. And I think I love that as an example, but that's also what I really like about PACOP as well, because anything that's been assessed or observed, there's actions to go with it. So that's not only important for the person receiving care, but important for the person who is observing those changes to know that those changes are important and they're valid, and that it is important for them to express that those changes have been happening in an environment that's going to take them, take them on board and take them, create an action from it.
Yep, totally.
So The next element covers both sets of standards. So I'll go to you first, Bron. And it is around the importance of documenting and communicating with the person, their family, substitute decision makers and carers, where care cannot be done in accordance with the person's stated goals and preferences. And what is your advice or strategies that you would offer clinicians who need to have these difficult discussions?
So I think the first thing I'd like to say to people, and it's not always easy, is don't be afraid, because I think often the people who are listening to you or who you need to talk to have more concerns or fears. And, you know, Sarah said before, being authentic in conversation is really important because people know when that's not happening. So I think there's all of that. And it's hard because if you're not used to having conversations, it can be really difficult. I think there are many instances when people's goals of care are not met in the context of the people who I look after, palliative care in aged care. And there are various situations that could drive that. Sometimes it could be that a resident has said, I want to stay in situ, I don't want to go to hospital, but they have a fall and there's a serious fracture. And really gold standard is that those fractures are fixed because it manages pain best, and it would mean that the person goes to hospital. And of course, when they go to hospital, there's always a lot of risk of interventions that maybe would never have happened if they'd stayed. And the person who returns to you is really quite debilitated and often has quite a short lifespan afterwards. So having early conversations with families about what is being observed, I think, is probably useful. Instead of saying, I think someone's dying, it's really looking at, you know, what were they like before this? What are they like now? Where do we think that where do we think their trajectory is? So I think that can be sometimes very difficult for the resident and all the families to accept, is that hospitalization ends up happening when it was really not wanted. We have many situations where a resident may want to stay in the facility until they die, and it's part of their goals of care. And then families, when they see the person dying, panic. Anticipatory grief, there's so many different factors, and they become quite insistent that someone goes to hospital. So I think it's tricky for staff in that situation because, perhaps the resident has become unable to make decisions for themselves. We talk about cognitive impairment particularly. There's quite a high ratio of cognitive impairment in residential aged care. Informally, it's about 80%. So now we're looking at people who can't enact their own decision-making, are relying on a substitute decision maker who has come to a point where they are frightened and feel that best care is offered in a hospital setting. And I think the only thing that staff can really do in that situation is try to explain what it might look like and how much intervention might occur. And that might be exactly what families want. They want more investigations. And what we also hope for then is that there's good communication between the facility and the hospitals around goals of care, what the original plan was, what we understand as aged care, the burden is for that person and the risk, and that is communicated to the team so that potentially there's early palliative care conversations happening in the hospital setting and a recommendation to come back to care in residential aged care. As far as documenting, the documentation's absolutely critical, because if you're not documenting the conversations you're having, no documentation, no evidence, it never happened. So I think it's tricky to stay on top of volumes of communication, which often happens in these situations. But even if you can just write a note and put bullet points in, just get the essence down of what happened, what you did, what conversation you had. It does happen. It happens quite a lot. I think one of the things we've seen is when staff are being able to show what they're doing and they're using the PACOP tools to explain what's happening in care conversations, that often changes a relationship that the families have with the care staff. And we see then a trust and a therapeutic relationship change. And I had one facility in Sydney where very diverse population, that facility never had anyone die in situ. Like the goals of care were always hospital transfer for palliative care at end of life. They started using this program, and in a 3-month period, I had a facility manager come on board and say to me in a community of practice we were holding, I have to tell you something, 10 people have died in the past 3 months and 6 of them died with us because we're using this program and we're talking to them about what's happening, and they trust what we're doing. So I think that if you've got a process and you can share what you're doing with families, it might also help with goals of care and that freak out that can happen towards the end of life.
Yeah, it means that they're not surprised, are they? You bring them along the journey with
you have to do that.
Yeah.
Small conversations, because this is the other thing, if you're regularly assessing someone and you're pulling families in, be it the SPIC, be it, these tools, have small conversations. Don't have huge, overwhelming conversations. It's like you said, Sarah, firing a warning shot. It's like, this is a significant change. They're not getting better. They're not going to bounce back.
Yeah. Great. What about you in that context, Sarah?
Wow, the first thing to say is, gosh, there was some pearls in there, Bronwyn. Like that, there's not much to add really. But my two, I've got a practical thing to say, which is the first thing that came to mind with this question is always on admission, trying to make sure that you check who the nominated support people are. Because what comes in a document to you from a hospital has rarely been checked, and might be some random person that they've assumed who's been there, but that might not be the client's nominated person. So I think that's a useful thing. Two examples. So exactly what Bronwyn has said. These situations are common, I think, and I've two examples that come to mind. One was a client up here who was kind of functionally quite well at home, but had dementia, and as a result, lived on her own, but was walking down the street, hopping on a bus, falling asleep on the bus, and then getting a fright when she woke up, and assaulting people when she woke up. So obviously, was very difficult for the family, and so she wanted to stay at home, and so that was very difficult. And then I had another client I remember in a specialist community palliative care service, a teenager who wanted to stay at home to die, but mum and dad desperately wanted her to go to hospital, and they wanted full CPR and resuscitation. And so, I guess the other thing I wanted to add is that just as a clinician, I think these ones are really hard, where there's this, the care or the situation isn't as the client would want, isn't what they want. And that's really hard to sit with as a clinician. And I think too, perhaps sometimes not how you would like it, right? And that's even harder, right? How you'd want it for your mum or your dad or your loved one. So I think it's just important to remember that, and remember that the client is at the centre. I have to centre myself back to this is what they want or the family want. That's an important point, I think. And as what Bron said too, I think being straight up and honest is important, and that builds trust. And I think bringing all these conversations back to the client, and often a little bit of what Bron said too, I think asking a client how they like information delivered is important too. How much information do you want? The information, do you want me to speak with your child? All of these types of things, and making
because some people don't, do they? Like some people are very much like, I don't want to know what my trajectory is, or like I don't want to know.
Absolutely.
That's okay.
Yeah. And sometimes the families actually also say they don't want that information shared.
Yeah.
And culturally, it's something we have to take into consideration, because we have many cultures where elders or are the ones that are making decisions around care.
Yes. Yeah.
And I think the common theme through what we all saying is that it really comes down to a relationship, building a relationship with the person that you are caring for, with their family and their carers and their support networks. But that's not just an individual's clinician's responsibility. It is the relationship that person has with the service. And there's lots of things that feed into that, like service culture and which are all kind of covered in other standards around national palliative care standards. But that relationship is so invaluable. You can't have these constructive conversations if that relationship with the person is not there first.
Yeah, and that kind of brings it back to the question before, Kate, about when do these conversations start, right? And it needs to be, early, right? So you can build a relationship with the client and their family and know them and know what they look like and have a good picture of them and they trust you.
Yeah, absolutely. I'm thinking time-wise, we might go to some audience questions. Got a couple of those that have come through. Kate, did you want to take the first one?
Yeah, so the first one comes from Liz. And Liz asks, what is the best approach for non-clinical staff supporting clients and support at home services who may benefit from palliative care but hesitant to engage with those services? How can we encourage these conversations in a supportive and respectful way?
I can answer that one. The best bit, this is completely, that was not a planted question, but the thing I use in my work is the beautiful PCA little booklet, which is about what matters most. There's a booklet and it's really pretty and it's a beautifully paced document that is about introducing the conversations around advanced care planning, but in a really palatable way. So that would be my advice, is if you're a non-clinician wanting to start a conversation, order some booklets and take it with you and just say, look, this is a document that we should kind of all be we should all be talking about what matters most, and this is about talking with your loved ones about who you are and what you want, and if you start that way, it'll grow.
And I just want to add to that, because I think some people think that that's all clinical, and that document has an accompanying set of cards, and if you go through those cards, it's things like, I want my pet with me, I want access fresh air and an open window. Now, if that's one of someone's goal, then it's quite likely they don't want to be in hospital because there's no open window there, so it helps you think about how someone wants to be cared for. And they're not, do you want a DNR? They're like, how do you want your care to be delivered? What's important? I love that resource.
And absolutely.
Sorry, Katie. It absolutely lands, that document. I love it. I was not paid to say that.
No, and it's not the first time we've dropped the what matters most discussion starter cards, because they are so invaluable. And I also really encourage any early career nurses, any students. I think it is a great way to build up your person-centered conversations and build up not your competence in it, but your confidence to do it. And one hot tip that I was given at a conference, that if you are still not comfortable to ask the person the question, have the conversation where you're answering the questions for yourself. And then that can lead into whether they agree with it, whether they don't agree with it, and it can lead that discussion to go further as well.
Yeah. And I was going to say, Advanced Care Planning Australia has some phenomenal resources and some videos and things that could be very helpful to look at. And just, again, like Kate says, familiarize yourself with conversations and how, like you'd say, Chelsea, too, it's not always clinical. It's about, where do you want to be? How do you want this to feel? You want your pet with you. I like that. Window open. It's really great.
Yeah. And they can lead into those discussions that go to clinical decision makings. Yeah. But it's having those at a higher level. Yeah. And then you can lead into those discussions and advanced care planning and those clinical interventions, because if that's the person's wants and needs for that particular thing, then that's not going to change with a medical intervention.
Yeah, that's right. We've got another. Oh,
Yeah,
sorry.
no, I was just going to say, if I had to sit down and do an advanced care plan at the moment, I'd really struggle if I was looking at the clinical aspect. But all the other stuff would be easier to work through. Sorry, Jess.
No, that's okay. And a lot of clinicians will say, if someone just gave me a list of their values, which I think those sorts of documents drag out, you know what they would
immediately
choose.
Exactly.
And that's just from your skill with working with people all the time. So we've got another question from Khaled. It said, I was planning to conduct some research to assess nurses' competency in terms of knowledge, attitudes, and practices related to palliative care. Can you please guide me on whether there are any validated tools or questionnaires available, including scenario-based or case-based assessment questions?
Oh, wow.
That's a big question.
It's a big one.
I don't know of any, to be honest. I think that maybe that's a question that has to go to some of the unis that have been doing work around that. I know UTS has been doing, Queensland University, QUT, and also Flinders.
Yeah, I think also to unpack it a little bit, when you're looking at competency, that is somebody's ability to demonstrate to do that, for them to be competent. So I will definitely look in and get in touch with people that could do it. But if you're looking at a competency around attitudes, maybe it's not a competency, maybe it's another type of assessment to kind of to gauge that and then to work with quality improvement. But I will definitely follow up, and that will be in a future email that we send out.
It will be.
I just want to say too, you're right, Kate, and I guess if you wanted to watch someone's end of life kind of conversations and assess that, in my old work, in this boot camp that we ran, we used an observational assessment tool. They're the types of ways that you can observe someone's level of competency. But
because you're looking at communication skills and things like that, and there's so many different communication models. A lot of it's taught in palliative care. There's a number of models that are, but I think a lot of the time when people are communicating, they don't even know they're following a particular model. It's really what suits them. Difficult.
Actually, Bron, I heard you say, if you're holding a notebook or a computer in your hand while you have this conversation, then you're not having a conversation.
That's right.
I love that.
Put
that stuff outside. Go and have a talk and then go back and fill it out.
I do think that we're looking at specialist services around this, grab the self-assessment tool for self-reflection, and if it is so the people that you are looking at, their attitudes towards things, maybe have a look at the standards and get them to do a self-reflection on it, and maybe that could be something that could drive your education strategy around those points. But we'll definitely follow up with that.
That self-assessment tool is PAXA, and that's a good lead-in, Kate. I might get you to talk to us a little bit about the National Palliative Care Standards Community of Practice.
Yes. All right. So the National Palliative Care Standards Community of Practice was launched at the end of last year. And each month, like we are doing today, we focus on one of the standards of the National Palliative Care Standards. So the members of the Community of Practice receive an infographic, a blog, information on the relevant national projects that support that particular standard, for example, PACOP, and a link to the next live webinar. So each resource supports learning in a different way. So the infographic was really designed for clinical nurse educators in mind, and there's 4 key messages to make it easier to deliver quick education on the run or even during team discussions. The blog offers a way to engage with the standard for those who prefer to learn through reading and reflection. And then the webinar brings it all together, and we explore the elements of the standard and create space for connection across the sector. So the community of practice really is about learning from each other, and I really welcome services who are completing this palliative care self-assessment tool that we've spoken about, or even looking at how they embed the standards in their day-to-day practice. I would love you to get in touch with me, and we can share those service stories with others, because we really want it to be a collaborative space, and we really want to learn from each other's experiences. So the QR code is now on the screen, and I expect a lot of expression of interest at the end of the webinar.
Okay, well, we are coming to the end of the webinar, so I'd like to thank all our panel members for their time and expertise today. It is so invaluable for all of us to hear how things actually, are working on the ground, and how you're implementing the standards alongside the tools and other things that you've got in place. Our next live webinar with some more fabulous members of the community of practice will be on Thursday, the 18th of June. Please invite your colleagues to register so they can watch at a convenient time also. You can always come back to them. A follow-up email with the further details and links. Could we just mute? Thank you. Sorry. A follow-up email with further details and links will come out to everyone in the coming days, so keep an eye out for that. The other thing I also wanted to just flag while we've got everyone online is that everyone's really familiar with the Oceanic Palliative Care Conference that we run every couple of years, and it's the most fabulous conference for the sector. Last time we had about 2,000 people there. Next year in April will be a combined Asian Hospice Palliative Network and Oceanic Conference. So we won the hosting rights for the international event. That'll be held in Adelaide in April. And I just wanted to flag for everyone that abstracts are open now. They close in August. So if you've got something you want to highlight, a fantastic thing that you've done, or a research project you've done, or something you're working on, then please pop in your abstracts. The other thing too is early bird regos are already open. So if you have, PD or something that you want to use up before this end of financial year, it's open now so you can achieve that at the early bird rate. So I just wanted to flag that too. But otherwise, we will see you all next month when we look at, which standard are we looking at next month?
So next month is Standard 5. You put me on the spot here, which is transitions with and between services. So I think we've got a couple of people from the community sector, which is going to be really valuable, but it is a really important standard in just having that cohesion across different services. So I'm really looking forward to that one.
Fantastic. And that language across services, the importance of that as well. So we'll look forward to seeing everyone next month. Thank you all, and thank you again to our panelists.
Thanks, everyone.
Bye.
Bye. Bye.